Hello, this is Renew Education. We're looking at case study, and this one in particular I'm going to call Bye Second Molars, meaning like bye second molars. I'm not a big fan of second molars, especially when the patient has three good teeth here or up here, meaning premolar, premolar, molar. Now, second molars to me come in handy for 3-unit bridges when they lose the first molar, or that they have a missing premolar and they bring the occlusion up. So patients can chew fine in the primary occlusion area, and when you bring the second molar into that position, then it acts into the primary occlusal areas. So these premolars here, premolars here, premolars here with the bridge, premolars here. So this is fully decayed, and this is decayed and hopeless as well. So let's look at the treatment assessment. The treatment assessment, I give an orange on the bone density, and the red is a facial bone in the particular area of the molar area that we're looking at, number 19. I give a light green on the ridge height and a green on the IA nerve. So that's pretty straightforward. There's nothing complicated here. The extractions are pretty straightforward. The second molar up there extraction, or these extractions here, there's massive decay around there. There's a hopeless case, and this is obviously hopeless as well. So let's take a little bit closer look at why I might give it a red or an orange on things. The particular area that I'm looking at right here is this line here. So we're looking right through that root, and here's what we see. So this patient must have a pretty heavy occlusion. They have some tori built into this area here on the molar area, but look at the facial plate, it's very, very thin. The other thing I don't really particularly like is how dense this bone actually is. So the density does affect the placement of the implant, and so I would not be doing any kind of immediate placement in this case. I would be grafting the case, maintaining that facial plate, maintaining that wall. Now, I gave it a green on the IA nerve because it's actually down here, but you can see how this constriction kind of comes in a little bit and goes into play. So the length here actually is not too bad. So let's say if we maintain the height of the bone across here with a graft, then I would say you've got a possibility of putting in a good 10 millimeter implant easy in this site. I wouldn't probably do an 11, but I would be doing a 10, probably a 10 by 5 diameter, and you would be putting it a little bit more distally than that. So you'd be more in this position here. Now, the funny thing here is you're not constricted to dealing with this tooth because that's going to be gone. So if you want to put the implant a little bit more mesial, you can. So here's something I started doing a while back. Since you're going to graft this site, and you have this septal bone here, right? You've got this piece of bone, you have these two socket sites now for the lower, and that's where you want the implant, right? You want the implant right down here. The problem you have is that this bone is still going to be very strong when you graft this side and this side. The bone here is going to be soft, it's going to be hard here, and you've got this very hard ridge to try to get your osteotomy in there, and what's going to happen is that your implant is going to go down into the mesial wall, because, well, your drill is going to go down to the mesial wall, and you're going to try to angle it. So I see a lot of this happening, that you're trying to force it, trying to get over there, but you can't. You have some softer bone here and harder bone here, and it pushes your drill in one direction, and you're going to get a little bit more mesial push on your implant placement, which is basically into the mesial, the old mesial socket. So what I recommend here, because you know this is going to happen, right? This is the whole point of studying these case studies and getting some predictive value out of it, is if we look at that septal bone that's there, that's in between the, or the inner, the bone that's in between those roots, which is right here, right here, you can see how thin that facial plate is going across that root here. And now I'm just driving into that bone. And now here's what you're going to need to do. You're going to go right where that bone starts, is right about here. You take a rongeur before you graft the site, and you clip out the piece of the bone that you want to purchase your initial drill into. So right here, I'm going to clip the bone out of this site here. So I know that's my ideal spot. When I go back in later after the graft is healed, 3.5, 4 months later, I go back in. I don't have hard bone here. I have soft bone all through here. Now, you're going to get it right between, or right, you can do some measurements. You can measure off of this, right? You can take a measurement from this distal contact point over the bone, and you know you're going to be there. If I clip this bone out here, right, I'm going to clip it probably pretty far. I'm going to clip it down to here. So now when I start my drilling sequence, this is all soft bone right where I want to be. So now as I'm kind of drilling in, I don't have that wall restriction. I might hit it at the end, but it's going to be a lot better that I'm going to be able to get it that far. This will probably be a little bit softer too, but now you can see that my insertion path and my compressive load for the crown into the implant is going to be far better than if I'm going to be stuck out here into the mesial root side. So clip that bone away. Here's the other thing I do. I clip that bone away and I smash it up into the graft material that I'm going to fill up the rest of the bone. And so I get my particulate bone, I clip this off, I smash that up, and then I put it into that, and now I have autogenous and allograft bone that's going to go back into that and suture that up and let that heal. So that's pretty ideal. What I don't do is, from this perspective of this site, I wasn't going to be grafting this site, but sometimes if I have a lot of particulate bone, I will just graft it for the patient and I won't charge. But my worry about taking bone from here, because this is more diseased bone, it's a little bit tricky because you might be putting bacteria from here into this site here, and that's not so great. So maybe you lace it with clindamycin or something like that just in case. So that's where I don't always transfer too much from one side to the next. Maybe I'm wrong. Maybe I'm a little bit more conservative there, but I try to maintain it just within that one site and do it that way. Over here, then you have the extraction over here. That's pretty straightforward. So here's what the patient always comes to me about. And they talk to me that a doctor wants to put implants into a second molar position. Now, a second molar position is a position that I don't really like restoring implants on, and I don't like putting implants in. And the problem I have is that I have a conflict with dentists that are fine with that, and they don't have issues with that. I tell the patient, sure, we can do that, but it's not part of your primary occlusion, and you may get about 20% of your chewing capacity out of that situation in the second molar when you put an implant there, but I got to charge you 100% of the money for 20% function. That starts to make sense to them. The other argument I hear a lot is, well, what about that upper second molars? Then I'm going to migrate down and blah, blah, blah. Well, you know, most of my clients are older. They're 16 above, and I don't see exfoliation of crowns or teeth coming out. So I don't actually think that's going to happen. But it doesn't matter. If you're not going to restore the bottom, you don't have anything to oppose it, and you don't chew on it that much, or let's say the patient does one implant at a time here, decides like, yeah, I can chew well enough. Well, so what if they lose the upper second molar? What does it matter if it does exfoliate? So I don't really care too much about that one, and I would just like to maintain the bone from here forward as much as possible for full arch options down the road or for other situations. This is not going to turn into up here, if this tooth goes out, then you got a 4-unit bridge. I guess you would be fine with that. At that point, maybe the patient's more interested in implant. They actually have bone going into that site right here. So they have an implant site for the upper where they have a 3-unit bridge. So there's possibilities, there's options, there's different, demands, I guess, from other dentists, like saying you got to do this or you got to do that. Patients get very confused. I try to leave it open as much for the patient to interpret for themselves, and I try to do that with dentists as well. So if you're the dentist that wants to do second molar implants, big deal, go for it. That's just not what I do. So when we do stuff at Renew and we train doctors, that's my philosophy. Doesn't mean you have to adopt it. Does mean that you can do your second molar implant cases all you like to do, for whatever reasons they are. So anyway, that's about it. So tune in again. We got more case studies coming at you, and this was also a good starter case for somebody that was doing something. I forgot to mention that. Anyway, tune in Facebook, subscribe on YouTube, and check out for our live broadcast coming up. Thanks.